Okay, so thank you for attending this this event, and thanks to Eric and Zsófi for inviting me. And of course, I'm aware of the Mind Foundation. I'm not. I wasn't pretty aware of this mental health section because I'm not a clinician and I'm not relating to mental health too tightly. But anyway, I had this actually this is a manuscript that I wrote in 2011 or something, and this is a topic which covers the most mental health that I've ever touched, and this is an occasion for me also that I can present this because I think it's interesting. It's pretty complex. It has a lot of information, and my presentation style is that I put a lot of things on the screen, but you don't have to read everything. So it's pretty okay for me that if you just remember that what was on some slide, and then later you will get the slides and the video, and you can just look up. So don't be afraid that there will be a lot of stuff on the screen. So yeah. So basically, please let me introduce myself. I'm Dr. Levente Móró. By title, I'm a consciousness researcher and a drug expert. I obtained my PhD with a major in psychology from the University of Turku in Finland in 2017. So I'm not a psychologist. I just had this major subject, psychology, within my PhD. My background is information technology. So my master's thesis is in information technology, software engineering. And I reside in Hungary right now, and here I do some activities, or I do all the activities related to drugs in Hungary. Mainly, I'm the leader of the Hungarian psychedelic community .hu. This is a website that had been around for 20 years, and it had some 10,000 registered members as a website, and we have a Facebook group with also like around 10,000 registered members. So this is the biggest website about drugs and psychedelics in special. And related to that, I have also this organization of PsyCare organization, PsyHelp. So these are the activities that I'm mainly known through PsyHelp, also internationally. So within consciousness research, my special field was altered states of consciousness. These include dreaming, hypnosis, hallucinations, and psychedelics. These were my special topics. And then I do everything which relates to drugs, including drug research on psychedelics, and I'm also an expert on new psychoactive substances, NPS. Then I do a lot of drug education on the website and on the Facebook group for like thousands of people, basically. I do harm reduction. We had this, or have this, I was a coordinator of this PsyCare team. So we did a lot of crisis intervention at parties and festivals. Internationally also, it's a very active team. It's I guess it's the one of the biggest PsyCare teams in Europe, and we are specializing to psychedelic crisis intervention. And I do some legal aid. I help attorneys and suspects and non-suspects not to become suspects in drug law issues. In the Hungarian drug law is my specialization. I do some drug expertise in EU projects. I have Ministry of whatever. We don't have a Ministry of Health here in Hungary. And I do studies and presentations and stuff like that. And I'm involved in drug policy, which is not very loved by the government anyway, but I did some NPS risk assessment, and I'm a founding member of the Hungarian Medical Cannabis Association. So I do a lot of social and societal activities as well. At the moment, I teach at the university. I have my own course on subject. It's called psychedelic psychotherapies, and I've been teaching that at 2 universities so far in Hungary. I have this website. I don't have a website really. I just put all my previous stuff, because like conference presentations and stuff like that, because I've been at like, I don't know, like 120 conferences throughout the years, throughout my PhD years in like 20 something countries, in all psychedelic conferences since 2004, all the major ones, not lately though. So I had a lot of things to do with drugs, basically. So my PhD thesis was titled Hallucinatory Altered States of Consciousness as Virtual Realities, and it investigated altered states of consciousness that are marked by hallucinations or occur in hypnosis or are induced by psychedelics. This is as to my understanding, this is the first and so far the only PhD thesis in Finland that was about psychedelics and in relation with humans and experiences. Today, as per the request of Eric and Jofi, I will present this topic about depersonalization disorder as a model system for consciousness. So this will include some things about consciousness, mostly philosophy of mind stuff, what is consciousness, how it can be modeled. Then we go into psychiatry, a psychiatric disorder model of consciousness. I did throughout search for the model candidates in the DSM-IV. As I mentioned, this is an old manuscript, so back then it was the DSM-IV, and I found it kind of easy to handle. And I'm aware of DSM-V that came later, and I didn't have the motivation to rewrite the manuscript to DSM-V category. So, but I guess I can make the point also with DSM-IV. I will focus on depersonalization disorder, DPD, and we will take a look at hallucinations, and in especially it will be about Salvia divinorum, because that's a very interesting plant and for consciousness research. So that will be my point. So this presentation will be about DPD as a model system for consciousness, and we will look at the scientific studies of consciousness and what the neural and cognitive theories are about the nature of the mind. And there had been a lot of models of consciousness suggested, and they are related to these subsystems of consciousness. In clinical neuropsychiatry, we will take a look at what candidate model systems could be there. And I did this throughout search through diagnosis lists for disorders in order to model consciousness with some kind of a disorder. So so I searched the DSM-5. Sorry, it says fifth edition. So no, it's a DSM-IV. Okay, I will correct that. And I propose that depersonalization disorder is the noteworthy candidate for a model system. And it affects all this cognitive, emotional, perceptual, and somatic subsystems of consciousness. And basically, DPD is about the feeling unreal. And it has an interesting connection with self-awareness, embodiment, and metacognition, and with the idea of being no one in the philosophy of mind. So I will then talk about hallucinogens, in particular Salvia divinorum and salvinorin A. That will be at the end, so it won't be that detailed because you might know anyway about salvinorin and salvia. And I propose that it is the most interesting pharmaceutical agent or pharmacological agent to experimentally induce depersonalization and derealization, and it could be used in clinical trials as a hallucinatory altered state of consciousness. So these will be the topics. And I have a lot of slides, but as I said, I won't read anything, or I won't read everything from the slides. And if you later want to look up, then just look up it. There's no point of reading all through the slides. So starting with consciousness, because my main topic was consciousness, I was doing my PhD in a consciousness research group in Finland. And consciousness as an explanandum. So explanandum is what is to be explained. It's an interesting topic. The scientific studies of consciousness are related to the brain and mind research. They are sometimes or usually embedded in cognitive neuroscience, which is also called the biology of the mind. And there had been a recent huge development in neuroimaging, which had advanced a lot this whole field of consciousness research. And the topic is conscious experience. So that is important because consciousness had been defined by a zillion different ways, but the conscious experience should be on the focus if we are talking about the human consciousness and human conscious experience. And this is one of the most complex scientific and philosophical issue to investigate. There was this science magazine which listed the top 100 most intriguing questions in science, and the problem of consciousness was number 2, because the universe was on place number 1. So it's very important in science. And there are lots of things belong to here: animal minds, artificial intelligence, exceptional experiences, and even quantum theories. So it's a huge field, and it's hard to define where the limits are. So the big question is a human subjective experience. We will take a detailed look at that, because the subjective is an important part of what we are. And it is also called sometimes that this field is basically the science of subjectivity, which sounds strange, because people usually define science as an enterprise to find out the truth and objective truth. But this is interesting that if we do study human subjective experience, then it's a science of subjectivity, and it exists. So consciousness involves some brain networks. This is without to tell that the brain generates consciousness or not, but that's a philosophical question, but that's for sure that consciousness involves some brain networks. And we can start looking at consciousness by systematically charting the neural correlates of the phenomenal experience. There are also some explanatory correlates of consciousness, which are not the neural correlates of consciousness. Neural correlates means that just a description of the brain and brain functions in order to explain consciousness, but explanatory correlates are different models, basically. The question is that how phenomenal experiences can exist in the first place. So if you believe some Nobel Prize winners and you assume that you are just a bunch of neurons, then it's pretty hard to explain that how a bunch of neurons can elicit something like a phenomenal experience that you are experiencing, or at least I am experiencing, or at least I have this feeling of experiencing, and I don't know about other subjects. That's also an interesting problem, that how can I know that other people are conscious? One of the studied topics is the binding problem, how the different modalities, different sensory content is integrated into a single conscious content. Like if there's a bird flying over there, then you see colors, you see movement, you hear a sound of chirping, and then you have some cognition or cognitive window opening and says that it's a bird, or even more detailed. But how these can be integrated into a single content, that's a very big question of the binding problem. In consciousness research, we can also measure contents and states of consciousness. And actually, the word conscious is associated with an awake and alert state. In contrast with unconscious states, such as occurring in anesthesia and coma and so on. So in consciousness research, there's usually a distinction between 2 levels of consciousness, at least. The first one is a primary or phenomenal or sensory or core consciousness. This is the subjective experience of being here and now. It is just this kind of this experience of being well, alive or aware or being conscious, without anything more detailed. And this my professor in Finland, Antti Revonsuo, said that this is like having the feeling of an inner presence. So we are present in ourselves, or there's an inner presence feeling that we exist, basically. There's also a second level, which is called secondary access, extended or higher order, or metaconsciousness, and that's an awareness of something. So this is directed at some object, object or some content that primary consciousness can reflect upon. So it's an object of primary consciousness. In some theories, there are some other levels as well, but these two are by different words, but these are always defined by philosophers of mind. So consciousness research uses human subjects who can report phenomenal experiences while performing cognitive tasks or being measured with neurophysiological instrument, and this correlation between the phenomenal experience and the objective measured data is one like avenue of research. So the important thing is the phenomenological viewpoint, so the experiential viewpoint, and there's always a subjective character of the experience. And Nagel, who's a very famous consciousness researcher, one of the, not oldest ones, but one of the first ones who were taking this phenomenological viewpoint, said that fundamentally an organism has conscious mental states if and only if there's something that is to be that organism, something it is like for the organism. It's like his paper is what is it like to be a bat. That's prototypical consciousness research paper. So it's always about this. It's like to be something ness. And the point is that biological research programs should reconceptualize consciousness as the phenomenal level of organization in the brain. This is also Ravenswood's idea, in order to give a proper explanation on the subjective conscious experience. So it's this is a kind of not monistic, materialistic approach, but this kind of accepts phenomenology as a level of organization. And that's the main point in this this approach. There had been a lot of theories and metaphors and models of consciousness that were proposed through the years and decades. And some theories of consciousness, like the most famous ones are, for example, the global workspace theory. That's a theory which uses the theater metaphor, as if the consciousness has a stage, and there is, if something appears on the stage, then the mind casts like a spotlight on the stage, and then it is how it focuses on some these secondary objects of consciousness. One of the recent theories is the information integration theory by Tononi, and that's more like a mathematical model. It computes an information integration kind of a number thing out of information, and it defines the more complex conscious states by this computable number. There had been the entropic brain hypothesis by, you surely know, Robin Carhart-Harris, who is a psychedelic researcher, and he applied his psychedelic research results into this hypothesis. There had been some models of consciousness proposed, such as the visual system by Nobel Prize winner Francis Crick and his colleague Christoph Koch, anesthesia as an unconscious state, dreaming as a word simulation, as a model of consciousness, coma, and epilepsy. So you may see that these are different states of consciousness which are thought to be models of how consciousness works. There's also a virtual reality metaphor, which had been detailed in my PhD thesis, but I don't think that we will go into that in this time. So the question is that what explanatory correlates should these models describe? And there is a statement that or claim that 4 fundamental properties are characterizing most, if not all, conscious experiences. And the one is the coexistence of segregation and integration in conscious scenes. That means that if you have a conscious experience, then you can segregate it to different parts, but still those parts are integrated into one whole, like an integrated concept or content of consciousness. The second one is the emergence of subjective first-person perspective, which is important because it's always you who are the experiencing experiencing subject from the first person perspective. Then there is a presence of affective conscious contents, like there is some emotions which are more like transient, and there's a mood which is more like a background, like a longer time affective state or content. And there are experiences of intention and agency that are characteristic of voluntary action. So you feel that you are doing things by your own volition, your free will, and this is directed at something. So you have intention, and you are an agent in the world as a subject. And then we go to discussion that how this whole thing relates to psychiatry. Kircher and David said that in some neuropsychiatric conditions, the basic tone of selfhood loses its natural givenness with subsequent changes in the perception of oneself and the environment. So this is about selfhood and oneself getting disturbed in neuropsychiatric disorders. Then it had been also said that the notion of consciousness must be acknowledged as the very epicenter of any concept of mind, such that any deep understanding of the disordering of mind, behavior, and emotion central to psychiatric and neuropsychiatric syndromes mandates a deeper understanding of consciousness. Basically, the bottom line is that consciousness should be studied for neuropsychiatric syndrome. And so observations from psychopathology may be integrated with phenomenological and analytical philosophy, cognitive psychology, and the neurosciences to form a descriptive model of self-consciousness. And this is what I do in this lecture, basically, so combining philosophy, psychology, neurosciences, and now also psychiatry and the psychopathologies. Because the bottom line is that the potential synergy between neuropsychiatry and consciousness research is evident. Psychiatric disorders could be utilized in consciousness studies. That's a very nice bottom line. So the second part will be about the psychiatric disorder models of consciousness. So we go into psychiatry, and first we take a quite a painstakingly technical and detailed look at what are the requirements for a model system. So model systems test hypotheses on working mechanism of bigger systems by using a smaller and simpler but adequately similar system. They explain significant processes. They describe the organization of entities and activities, and there must be some dynamic models of the mind, because there are some temporary and metastable modes of operation or states of mind that are changing by time and then changing back by time. And the basic concept here is the states of consciousness by Charles Tart, who is a very, very famous altered states of consciousness researcher. So states of consciousness researchers, he defined this whole field of altered states of consciousness, ASC. And it appears that there are separable parts, subsystems, or components that exhibit significant variability within consciousness, and these can be assessed, these subsystems, by neural, phenomenal, and behavioral measurements. And so studying altered states of consciousness provide a detailed insight into the differentiated working mechanism of the subsystems of consciousness. So what are these subsystems of consciousness? Let's jump back to consciousness. So this is a Tart's chart about what are the subsystems of consciousness. He made a distinction between 10 different subsystems. There are some other lists of consciousness subsystems or components or parts which have a different number of subsystems. So these are obviously not very exact, but it's a kind of a cognitive psychology approach. And of course, those arrows between the different subsystems are quite vague and not scientifically based exactly, but you see like vaguely that how these might be connecting to each other. And this is the description about these subsystems. Maybe I don't go into those because some are pretty self-evident, such as memory or emotions. And then, so these are the basically cognitive functions. as well as somatic, perceptual, and emotional. So these are maybe four big categories to categorize subsystems of consciousness. So in psychiatry, models are also used. For instance, traumatic brain injuries and organic diseases had been used as models because they cause neurobehavioral symptoms and psychiatric disorders. And therefore, they provide insight into the relationship between neural and mental functioning. These psychiatric disorders may hint about the localization of brain functions by describing the manifesting functional deficiencies. You all know the case of this railroad construction worker who accidentally blew up this rod which went through his eye socket and brain, and he had some very peculiar brain function deficiencies actually, and so this was the maybe the first case when there had been some hint about this localization of brain functions. And some models in psychiatry, they mean by one, or there is one use of this model word which means the comprehensive views or overall approaches to mental disorders. Like we had the disease model, the psychodynamic model, biopsychosocial model, cognitive behavioral model, and social model in psychiatry. So these are about views. And on the other hand, model is used in the sense of animal models, which led to major advances in understanding disorders, obviously. And so they model various symptoms that implicate some neurobehavioral and neurocognitive processes or simulant relevant aspects of particular neuropsychiatric disorders. So this is the two different uses of the word model. So what could be the requirements for a psychiatric model of consciousness? So it should be a smaller and simpler but adequately similar model, which is based on human subjects or human subject data. I found three necessary requirements based on the literature. One is that the model should cover all this structure of consciousness, like by subsystems, possibly the widest range of elements of the phenomenon that we want to model. So this is a core condition, because the more elements or subsystems are included in the model, the more robust the model is. Then there should be a dynamic or functional coverage of this model of consciousness, because it should include the functional variability, like different altered states, like how a state can change into another state and then back. And so these transitional processes should be explained by this model. Yeah, so these are the process level explanations that what happens in the model as compared to the structural. And the third one is the phenomenal or experiential coverage. So this model of consciousness should be based on the reported subjective experiences as the primary source of data, because that is what validates the model against the modelable phenomenon. Because so the idea is that the subjective experience is the main thing about consciousness, and if we just study neural correlates or we make a model with neural correlates or observed behavior, then they are not very strong validatory evidences for our model. But if a human subjective experience validates the model, then it's a harder evidence. There is also an optional fourth requirement, and I tell you why it's optional. The requirement is this metacognitive or metaconsciousness coverage, so that this proposed model of consciousness should have some self-reflecting capabilities that are adequately similar to the modelable system. So self-reflecting capabilities are when a system knows its own state. This requirement of metacognition may be too strict, and it could exclude some otherwise promising approaches. Like there would be a very hard requirement for an AI to be able to be metacognitive, like to reflect on its own state or on its own conscious state, like in metaconsciousness. And the dreaming is another otherwise very promising approach, but in dreaming there is no metacognition except for lucid dreaming, which is a kind of an exception when there is some metacognition about the state of dreaming within dreaming. So there also the reason for this the fourth requirement of metacognitive or metaconsciousness coverage to be optional is because there may be a delay between a momentarily self-unaware state and the later self-aware state. So like it's a very simple, like when someone is in hypnosis, a hypnotic state or in a trance state or in a meditative state, then there is no self-reflection at that moment, but later the person can self-reflect on these previous states. Like it's like in the middle of a meditation when someone is thinking that, oh, I'm meditating so well today, then it's obviously it's a paradoxon, but so this illustrates that there might not be metacognition all the time, but later there can be some retrospective reflections of metacognition on this state. So the ideal model candidate is it doesn't explain the absence of consciousness, nor its graduality, like some leveling of consciousness. Because and the good thing is that psychiatric patients are conscious, as opposed to like some other medical patients who are unconscious, like in coma patients. And secondary consciousness is also possible to examine in psychiatric patients, so they are able to describe their contents of consciousness. So there could be very rich phenomenological data about the patient's conscious contents, which are like perceptual experiences, bodily sensations, emotional reactions, moods and thoughts, and inner speech, sense of agency, self, and subjective first-person perspective of the world. So we can all ask the psychiatric patients about these things, and they are conscious enough to answer. So the ideal candidate for a psychiatric model of consciousness is a disorder of the subjective experience. So we should search for something which is a disorder of the subjective experience and not other things. And so this is a disturbance in the phenomenal level. What is it like to be-ness level that gets disturbed in this psychiatric model, ideal model candidate disorder. And so this is the point, is that the core explanandum of consciousness is phenomenality. It's a there are neurocorrelates as well, but phenomenality, like the phenomenal human subjective experience, is the core explanandum of consciousness. Explanation is also advanced by charting the neurocorrelates of the subsystems of consciousness, as well as the binding processes that integrate the subsystems. But these are not about phenomenality. These are more like the technical stuff with brain cells and brain networks and brain chemicals, and so their interplay. But phenomenality is the number one interesting thing. So the ideal model candidate can be summarized that it should have its symptoms related to most subsystems of consciousness. This is the coverage. Produce a notable variability in mental functions. This is the dynamic requirement, and to be reportable by the subject himself or herself. This is the phenomenal requirement, and optionally, it's also important that it leaves reality testing intact. Reality testing is when someone is able to reflect on his or her own consciousness and knows in what conscious state he or she is at the moment, and realizes that this is the basis of his or her subjective experience. So let's search for model candidates in DSM-IV. I will check the time. Time is not that plenty, but anyway. So in DSM-IV is a huge manual. It has, although just a few references to consciousness, like basically it's about the loss of consciousness or unconsciousness once, or the integration, alteration, disruption, constriction, disturbance, or impairment of consciousness. And in DSM-IV, disorders are grouped into 16 major diagnostic classes, so it's such a huge amount of data that the manual scoring of disorders and subsystems is not feasible. So I did a comparative search through comprehensive diagnosis lists for these disturbances, deficits, and impairments in the components and correlates of consciousness in 3 search steps. So one was a broad exclusion of some of these 16 diagnostic classes. The second was a between category comparison of what left out of these. And the third one was a within category comparison of the most promising candidate. So my search step number 1 was exclusion. So I kind of intuitively speeded up the process of search by excluding some of the most unlikely suitable disorder categories, or the most unlikely candidates, like mental disorders due to a general medical condition not elsewhere classified. It's too etiologically based, and it's there is an open-ended reference to undefined medical conditions, so it was too vague. Disorders usually first diagnosed in infancy, childhood, and adolescence. It's a division according to age at symptom presentation, and this is admittedly listed for diagnostic convenience only in the DSM-IV. And I excluded eating disorders, sexual disorders, and somatoform disorders because these are overwhelmingly related to the physical body and not in the mental domain. Then I excluded adjustment, anxiety, fetishes, impulse control, mood, and personality disorders because they in these have some. The emotional subsystem is overrepresented because these are mostly like emotional or behavioral or interpersonal categories. So these are not likely to be good candidates. And then I was comparing the classes or between classes that were left behind. So there were 5 classes. One was the delirium, dementia, and amnestic or other cognitive disorders. They are usually, their etiology is a general medical condition or a drug or medication or toxin, and these are limited to cognitive subsystems. And dissociative disorders are the disruption in integration of consciousness, sounds good, and memory, identity, or perception, and there are quite many subsystems related to dissociative disorders. Sleep disorders, they generally or mostly or quite often relate to other disorders, and the sleep disorders involve an unconscious state with no subjective experience, dreaming, and no metacognition except lucid dreaming. And substance-related disorders, they have a lot of different substances which are in the DSM-IV for causing some disorders, including some intoxication and cognitive disturbances, delirium, hallucinations, and these are overtly visual. Exteroception is the subsystem that is involved, and then schizophrenia and other psychotic disorders has also delusions, hallucinations, and disorganized speech and behavior, but they have an impairment in reality testing. So the schizophrenic and the psychotic patients are not necessarily realizing what is real and what is unreal. So this was the comparison, and I put these little marks into this. Obviously, if I wanted a real publication, then I would have to involve some other judges and make judgments of these by different judges and do some inter-judge, inter-agreement ratings and so on. But this was just a quick search and a quick job. So this is a table that what is included or what type of subsystems are included into these DSM-IV disorder categories. And the point was that in dissociative disorders, practically all subsystems of consciousness are affected. So we will take a look at this in even more detail. Wait a second. Yeah. So if we take a look at reality testing, then we can see that in substance-related disorders, reality testing is impaired. In schizophrenia, it's also impaired, but in dissociative disorders, it remains mostly intact. So this is the point that I would like to make, that dissociative disorders are are different in this sense that in reality testing. So that may make it a good candidate. So the third step, was a within class comparison, because dissociative disorders have some sub categories. And dissociation actually is when the individual deals with emotional conflict or internal or external stressors with a breakdown in the usually integrated functions of consciousness, memory, perception, or self, or the environment, or sensory motor behavior. So it basically is the breakdown of integration. And there are the subtypes are dissociative amnesia, which is a memory impairment type of thing, and then dissociative fugue is a traveling away and have some impairments in personal history and identity. Dissociative identity disorder, which is formerly called multiple personality disorder, which comes with an identity fragmentation, and two or more distinct personality states are controlling behavior. And there is depersonalization disorder, which is a feeling of being detached from mental processes or body, but intact reality testing. And so this is the thing that DPD is a dysfunction of the subjective experience where reality testing remains intact. So this is what we actually were looking for. So DPD is described quite nicely by the phrase feeling unreal, because there's a feeling of being detached from one's mental processes or body, accompanied by intact reality testing. And there's a definition in psychiatric manuals, like in the DSM-IV, in DSM-V, it's called a little bit different, and ICD-10 and ICD-11. They have different codes for this DPD or DPDR. And subjective descriptions include that except for feeling unreal, it's the patient said that I'm numbed, I remote, automatized, in a dream, stoned, half asleep, not awake, dead, or a robot. So it's by other than feeling unreal, it's a composite. DPD is a composite of 4 correlating symptoms. One is an anomalous body experience, like feelings of disembodiment. Then there is emotional numbing, anomalous subjective recall, and derealization, like alienation from surroundings. And these are also like termed very kind of elegantly as a desomatization, de-effectualization, depersonalization, and derealization. So we will use these terms for these descriptions. And this is a table where these 4 kind of labels are described, as well as what are the main symptoms in these symptom domains. So this is I'm not reading this, but we will use this later. And the relations to subsystems of consciousness can be by the chart says that that they are kind of relating to these the same subsystems within these 4 domains and categories. And if we take a look at the fundamental properties, fundamental properties of conscious experiences versus the characteristic dysfunctions caused by DPT, so then we see that this segregation and integration and the subjective first-person perspective and the effective conscious contents and intention and agency as fundamental properties of the conscious experience. But in DPD, there's a dysfunction like a disintegration, the lack of ownership of the subjective experience, disturbances of affective conscious contents, and diminished intention and agency. So we see that all these fundamental properties of consciousness are somehow dysfunctioning in DPD. So the symptoms are mentioned in the DSM-IV in relation to other disorders like substance-related or schizophrenia or anxiety, and also mentioned as a symptom of borderline personality disorder in Axis 2. And the effectualization is not mentioned in DSM-IV, but it still not by this word, but it still applies. So if we looking at these components, these 4 components, then we can connect these, like the somatic, perceptual, cognitive, and emotional. We can connect these. We will see later that where too. So to reduce DPDR symptoms with pharmacotherapy, there had been some approaches like SSRIs, antidepressants, anticonvulsant drugs, kappa opioid receptor antagonists. So these reduce the symptoms of DPD, and to induce DPD, either accidentally, deliberately, or experimentally, cannabis and cannabinoids are doing that induction. Serotonergic hallucinogens like LSD, psilocybin, DMT, and the serotonin receptor agonist, NMDA receptor agonist ketamine, and selective kappa opioid receptor agonist anodolin and salvinorin A. So salvinorin A is our special interest, so we will continue with that one. So this we can see that to reduce DPDR, kappa opioid receptor antagonists can be used, and to induce DPDR, kappa opioid receptor agonists can be used. So by salvia, we go into the domain of hallucinations. I will check the time. Okay. So basically, there's a huge universe of drugs, including different categories, out of which psychedelics is obviously our main interest, but there are also different categories of stimulants, psychiatric drugs, depressants, cannabinoids, and so on. So this is a very nice chart, and if we just zoom it, then we will see that within the category of psychedelics or hallucinogens, there is Salvia divinorum in this nice map. And so we focus on Salvia divinorum now. But we take a look what hallucinations are. So what is the characteristic of hallucinations? That they can appear in sensory organs, different sensory organs, or all sensory organs, plus they affect emotions and attention and perception. There is a dispute ongoing if hallucinations are a sign of mental illness or if it's a normal phenomenon. The first one is a medical approach, the second one is a psychological approach, and obviously this is a continuum. So there is these are the both ends of the continuum, but otherwise hallucinations are somewhere in between, or most of them are somewhere in between. So because they can appear, hallucinations can appear with or without neuropsychiatric disorders. Some are spontaneous, like related to sleeping, dreaming. Some are pathologic, related to illnesses, and some are induced, related to hallucinogens. And the phenomena that are inside the hallucinations are some are spontaneous, like hypnagogic hallucinations, dreaming, hypnopompic, and sleep deprivation. There are some pathologic hallucinations related to illnesses. Firstly, alcohol deprivation in delirium treatments, when you see pink elephants running all around, and in schizophrenia, Parkinson's disease, Charles Bonnet syndrome, and so on and so on. And then the induced hallucinations are related to hallucinogens. We will see at the next page. Hallucinogens are divided to or quite often to 3 categories. One is the deliriants, which affect the acetylcholine system. Some plants and some ingredients or active ingredients are listed there. Dissociatives affect the GABA and NMDA receptors, and psychedelics of our interest, which are usually serotonergic psychedelics. Salvia divinorum and salvinorin A make an exception to that. And we had this survey where we used this distinction of psychoactive substances, and you can see that within hallucinogens there was the psychedelics as a subclass, and within psychedelics, if we listed major psychedelics, and Salvia divinorum was one of them, even though it's not a serotonergic like the others, but it kind of locates in these subcategories within psychoactive substances. We also charted that what are the purposes of substance use. So this is just to take a look at why people use drugs, for what purposes, and our results with these 14 different classes of substance use were crystallized into this chart. The bigger the number, the more relevant the connection between a substance and the purpose of the use of that substance. And you can see some connections that you pretty much should be aware of, like using alcohol for social interactions, or using amphetamines for physical endurance, strength addition. And the interesting thing is this LSD psilocybe mushrooms block with religious and spiritual purposes and self-knowledge. And Salvia divinorum is also in this category, like the purpose of salvia use is for religious and spiritual purposes and self-knowledge, although not as markedly as LSD and psilocybe mushrooms. And you can see that there's an absence of the other purposes, which basically points out that salvia is not really known what to use for. So it's not very markedly enhancing any kind of systems or cognition components that it could be used for a very, very particular purpose. So it's kind of like it doesn't have this purpose, or so far nobody had found a good and very obvious purpose for using Salvia divinorum. So this is the salvia plant. As you may know, it's a hallucinogenic mint or sage. It has a traditional use in Mexico. Recently, it had been used recreationally. You might find lots of YouTube videos where people smoke salvia and then do funny things or scary things. It's usually smoked as recreationally, or in the traditional environment, it was chewed. It's a very short duration drug, just 10-25 minutes is the total time of effects. The psychoactive ingredient is salvinorin A, which is a potent kappa opioid agonist, and the effects are reported to be very unique, as it causes space-time distortions and entity encounters. Unlike other hallucinogens, these are, I guess it's very rare, and it does the thing in a very short time. So this is why it's called very unique. As I said, traditionally dried leaves are chewed to induce visions. This is hard to use in clinical trials because absorption is totally kind of uncontrollable. So recreationally, users also smoke fortified leaves, which means that the plant extract is reabsorbed on the plant material, is reabsorbed into the leaves. This is what had been used perhaps in clinical trials. So it's a more controllable, although obviously intravenous injection is the golden way to use any substance in clinical trials. It has a brief acute psychoactive effect. This says that the peaks around 2 minutes. That means it's not the effects, but just the peak, and then rapidly dissipates. There's an increased insight, improved mood, calmness, increased connection with universe or nature reported. And it had been found that it's physiologically safe and psychologically well tolerated. There are no significant adverse events observed or reported. There's no evidence of persisting adverse effects at 1 month follow-up. And subjectively, people said that they feeling like someone or something else, 14% of subjects said, or things seeming unreal, 32% of the subjects said that. And dissociation and detachment, like depersonalization and derealization symptoms were reported. So this is the connection possibly between the effects of salvia and DPD. And if we take once again this table and then compare with the salvia divinorum and salvinorin A effects, then we can see a striking similarity in the components of somatic, perceptual, cognitive, and emotional domains. So desomicization, derealization, depersonalization, and de-effectualization all happen in salvia divinorum experiences. Desomatization is there is changes in the perception of size, weight, and posture. There is this twisting force reported quite often in connection with salvia experiences. So the body starts to rotate around one of the axes. And derealization means that there is no boundaries between inner and outer reality, a sense of unity. Subject said, wherever I looked was especially beautiful. And depersonalization is like understanding the universe and so on and so on. De-effectualization is sense of reverence, more connected to other people. So all domains are addressed by the salvia experience. I kind of skipped this the neuro part of this presentation, although there would be a lot of things to talk about in how neuroscience of salvia works. But very briefly, salvia's main ingredient, salvinorin A, is a strong agonist of kappa opioid receptors, and these are found in the claustrum. This part of the brain called the claustrum in high density, and the claustrum had been studied by Francis Crick and Christoph Koch. And as Crick went into consciousness research after receiving his Nobel Prize, and so they actually said that the claustrum is a candidate as a conductor of consciousness, or kind of the seat of consciousness, although later research found out that some traumatic brain injuries that involved some dysfunction of the claustrum, or even very major dysfunction of the claustrum, still had those subjects conscious. So the claustrum is not a necessary, at least not a necessary part in somehow related to consciousness, but it was still or is still an object of investigation as the kind of a conductor or seat of consciousness. The bottom line is that scientific research with psychedelic drugs seems to have a considerable and so far very unexplored potential for studying human consciousness. So this is what I've been trying to do since the last 20 years, connecting consciousness research and psychedelics research up to maybe the mid 2010s with very little success and very little connection. I've been at a lot of consciousness conferences when there were no topic of psychedelics, and I've been at a lot of psychedelic conferences where there were no topic of consciousness. And maybe since 2016 or 17, there had been some thematic sections in consciousness conferences dedicated to psychedelics and vice versa. So the very unexplored is it's still a very valid description of research of consciousness and psychedelics. As I did PubMed search yesterday, I found only 239 results when the search word was salvia divinorum, and only 350 in connection with salvinorin A. And you can see I marked the year 2000 on both charts. So there was virtually nothing about salvia or salvinorin between or before the year 2000. And then is this psychedelic renaissance is well visible, although it looks like there had been less and less research on salvia. So maybe salvia had its highlight in around 2000, maybe 10, and it's kind of declining once again. It's probably because it's too strange, it's too scary for most of the people. There are only a few fans of salvia, so the salvia fan club is not very popularized, and so it's still a question that what could we do with salvia and salvinorin A? If someone gets a good application, then please tell me as well. I also did this search for clinical trials with salvia and salvinorin A, and found only eight clinical trials in total with salvia divinorum and salvinorin A. So this is a very this research is in its very baby steps so far, and I would be really interested if someone would do such things, and I possibly would be involved as a subject or as a researcher if possible. So if you know any collaborants, then please tell me as well. Okay, so thank you for your attention. Maybe it was a little bit longer, but sorry for the technical things in the beginning, technical disturbances. And this is my first experience with salvia. Actually, I was just touching a salvia bush at my very first psychedelic conference, which was called Exploring Consciousness. It was in 2004 in Bath in the UK. And since then, I've been a salvia fan, and I hope I can turn on some other people to this extremely interesting, in consciousness research terms, plant. Thank you for your attention.